Well, welcome everyone. Order to this session of the Health and Social Care Select Committee. Today we're holding a session as part of our work on the 10-year health plan, looking particularly at government's ambition to shift care from hospitals into the community and what needs to be done differently to achieve that. So today we're joined by two panels. We're very, very lucky. The first will run for roughly an hour and then we'll move on to the second. So thanks to all our participants for being with us and everyone for watching at home. So I'm going to get cracking. In my lifetime, there have been a number of different initiatives to do exactly this shift. In '87, there was the Promoting Better Health White Paper. In 1990, the NHS and Community Care Act. In 2006, we had Our Health, Our Care, Our Say, a new direction for community services. In 2014, the NHS 5-year forward view had a go, and in 2019, the NHS long-term plan also set out a vision for integrated place-based care. And here we are. So my first question is, bearing in mind, we've tried this before, and I'll ask all participants to have a go at this. Perhaps start by telling us who you are and where you're from, and then if you could answer, what do we need to do differently this time? Could I start with Stephanie, and then I'll move to Saffron and then Melanie. Stephanie Elsy, welcome.
Thank you very much indeed, Chair. I'm Stephanie Elsy. I'm Chair of the Bath and North East Somerset, Swindon and Wiltshire Integrated Care Board. I suppose there are a couple of things that I think are very different this time. First of all, the changes that have happened since the 22 Act have completely changed the relationships, if you like, between different parts of the system. Previously, it was competitive. That was the way that it was set up. This time, we have a duty to collaborate. And that is a really, really big change. Secondly, I think there is a much better alignment of incentives for organisations within the NHS and local government to work together to achieve this shift. As you rightly say, Chair, everybody agrees it's the right thing to do, and I certainly think it's the right thing to do. So I think we have a much better context, if you like, and framework for that to happen. And I think the final thing that's different, perhaps, to previous years is that we have a really significant burning platform, operationally and financially. You all know the enormous pressure that the whole of the system is under at the moment. That means, and as far as I'm concerned, the only way that we will be able to continue to meet the demand, to meet it more effectively perhaps than we are at the moment, and indeed to meet the demand that's coming down the track in the future with the ageing population and so on and so forth, is to achieve this shift. Because it's really important that we help people to stay out of hospital, and it's really important that when they're in hospital that we're able to get them out safely back home or to wherever the best place is for them to be. And then the other burning platform we have, of course, is financial. With the conditions that there are now in the public finances, we simply can't afford not to do this. It's essential. I think it's really, really crucial to the future survival and health of the system that we get this shift.
I think we're all agreed on all of that. What we're trying to learn today, though, is, are there lessons from the past? So I'm hearing one around duty to collaborate, really important that we keep that going. But if we could focus just initially on the past, what had we learned? And therefore, what do we have to absolutely emphasise in all of that in order to progress this so that we actually embed it? So perhaps Saffron Cordery.
Yeah. So I'm Saffron Cordery. I am Interim Chief Executive at NHS Providers. We're the membership organisation for all types of provider trust in England. So we encompass acute hospitals, mental health services, community and ambulance services. And I think building very much, I agree with everything that Stephanie has said. I think that in some ways there's nothing new under the sun, and you've just said that, we've got a timeline of shifts to moving care out of hospital, if you want to define it like that, and try and integrate local services more effectively. I was in local government in the 2000s. It was all about local strategic partnerships, shared local targets and things like that. It's been around for a very long time. I think what we do need to focus on is perhaps what hasn't worked in the past. So I think we know that a narrow focus does not work. So I would say in looking at this particular conundrum, moving care out of hospital into the community, I would say moving care out of inpatient settings, we need to encompass mental health in this. It's absolutely fundamental. So it's about broadening out, encompassing mental health in our definition of inpatient. I think we also need to redefine the challenges and issues that we're trying to solve. Stephanie really set them out well, but I think when we're looking at the solutions, we need to not just be looking at how we achieve narrowly drawn targets. So, we all know about the 18-week target. That's going to be the big driver for the next 4 or 5 years. That's absolutely fundamental, but in thinking about how we achieve that, actually shifting care is fundamental to that. So we've got to make sure that we don't just focus on big national popular target over here without encompassing what needs to be done locally. There are a host of barriers, and we've learned a lot on the way. I think narrowly drawn targets, first one, mitigate against really looking at how we enable good quality of care and also patient flow, which is fundamental. I think that at the moment there is a real lack of understanding of all of the nature of the offers that are out there. So I don't think that across the piece there is broad understanding of what community services offer, from kind of health visiting to speech and language therapy to all sorts of services on the ground that really, really help people stay fit and healthy at home. And when I say that lack of understanding, I don't mean from the public, I mean from across local systems delivering local services. I think we've got a real challenge in terms of the nature of the funding. It's hugely fragmented. It's often short-term. So if you're in primary care, if you're in community services, if you're in mental health, if you're in dentistry, if you're in an acute hospital, you have different funding streams and different types of funding. That's incredibly difficult to navigate if you're all meant to be focusing on a single goal and aim. I think also the nature, particularly for community services and some mental health services, of having block contracts. So you only have a defined amount of money. Whether your demand goes up or down, you've just got this money to work with. You would never see that in acute care, and I think we have to remember that. So what is expected to be delivered in settings outside of hospital, the budget is not elastic there, and that is very
on this point we are certainly going to be coming back, so I might stop you to allow some colleagues to dive into that. Melanie Williams.
Morning, Chair. So I'm Melanie Williams. I'm currently here as the ADAS President, so Association of Directors of Adult Services, so here bringing a social care perspective. But in my time in Nottinghamshire, so my other part of the week is spent as a Director of Adult Services in Nottinghamshire, and I sit on the Integrated Care Board, so kind of got some of that reflection to share. But I think from a social care perspective, there have been 3 main initiatives we've been working at, probably for about 15, 20 years, that have achieved some of that shift. So we've had a Better Care Fund for 10 years, which intended to integrate services and prevent admissions to residential care alongside emergency care. We've had the shift, and it's been referenced within mental health, so the closing of campuses and moving away from asylums to community care, and then the community mental health transformation programme, attending to to support more and more people in the community. And I think importantly, there's a lot of lessons to learn from transforming care, building the right support, which is where we're supporting adults with learning disability and autism, often being very, very long stay in institutional care, to be supported well in the community. So I think there are some learnings from that. So the first thing I think is about having a clear policy expectation, so being clear about who we're talking about and what we want to achieve based on their needs, so rather than on settings of care. So I think that's a really important lesson. If we just describe settings and moving people around rather than attempting to meet people's needs in a different way, which ultimately is our goal. And then we need to make sure that the metrics and the measures follow the policy. And I mention that because when we think about the Better Care Fund, one of the tensions is that we've had incredible drift from its original purpose, and we've added in metrics and levers and expectations, which really have sort of spread its focus. So having that clarity of focus of what you're measuring and measuring the policy is really important. I think, and it's been touched on about the funding flow. It's been really clear what your programme spend is. So what is the spend in the areas that you're wanting to move away from, and how does that shift in practice into the areas that you deliver? And if you want to do that at pace, that's where you need to invest in the outcomes first. And we see that really in the transforming care work, where we had funding agreements that followed the individual. Unfortunately, it didn't follow ahead, so we weren't able to provide different sorts of support in the community ahead of that. And certainly then, that hasn't been maintained over time. So particularly things like capital is really important. If you want to support somebody in the community, they need somewhere to live. So having a home is really central to that policy. So somebody needs a place of support. So that's some really important learning. And then I think it's about burning the old models, if you like. So one of the things we tend to do is drift back. So if we think about community mental health transformation, we see the rolling back of investment in community in crisis teams and going into the acute sector into adult mental health. So rather than sort of, if you like, making sure we close off those old models of care, so we constantly drift back. There's like a gravitational pull often to building-based services in terms of status, safety, feeling of comfort, professionals.
Yeah, and you think the best way to do that is, decide to move away and then shut it.
Yes, when we've had the really successful programmes of moving people's support, it is about then closing off the old models, not just for financial flow, but so that then we truly are committing to a new way of working. Would be one of the things that I think is a learning. And then I think one of our challenges and barriers is that where these things work the best, it's because you've got leadership that works in partnership, can mobilise a workforce, has a partnership culture and has some local drive. That doesn't exist everywhere, so therefore you will have variation. So it's worth considering in the policy expectation how we tackle variation.
One of my questions was what local authorities need in this space. And so I'm hearing, what is it? Is it training? Is it support? What do they need from government in order to be successful to deliver what you guys are delivering?
So I think in terms of the shift from community hospital, having a really clear remit for health and wellbeing boards and having that local partnership and the public health approach is going to be crucial to the success. That's one of the things to be considering, is what is the role of health and wellbeing boards and local government partnership. It's much broader than just social care. It's about housing, debt management, a whole range of things available to people. So that would be one of the things to consider. Clearly this isn't looking at adult social care reform, but if we're not reforming the way that we work through the National Care Service and the other aspects of reform, then we need to be really clear about how we achieve that in an unreformed social care system as a part of that work. And then the local accountability and leadership is really important. So these initiatives work best where you have single accountability, single leadership. So it's worth considering how the local authority can play into that. But that will depend on the group of people we're supporting. So for some people, they won't, somebody that I support in adult social care won't need any health input, and vice versa. People working in accessing treatment don't necessarily need a social care service. So we have to be really clear about what solutions we need for what group. And like I said, it comes back to the policy expectations.
And then on the other side of the equation, we've got the trusts who are running the acute settings. What do they need in order to help achieve this shift? Perhaps Saffron, Cordery, if you could answer that.
Yeah, I think what we absolutely need to see is, and I think I said it before in my previous answer to the question, I think how we focus on the types of contract that we are thinking about. So at the moment we're in a situation where if you're in a community or to a lesser extent in a mental health service, then your services can be re-procured every few years. Think about that in terms of you're running a health service that is really critical to a local population, but after 3 years, all the investment that you've put in, it could go somewhere else. Now, sometimes that's a good thing. If you've got a failing service, then the opportunity to be able to move it somewhere else is really, really helpful. But often what we see is massive disruption. It's very wasteful in terms of investment of funds in re-procuring. So I think a shift from that model. I think the proposals that we've seen from both Amanda Pritchard at NHS England and also the Secretary of State in terms of a change to, over time, to a different model for integrated care boards so that they take on the strategic commissioning role, because that is the bit that I suppose from my perspective and my members' perspective is that makes real sense of that integrated care system model. So it's about health inequalities, it's about understanding population need and then commissioning on that basis. And it's about making sure that, you know, we're looking at things, the wider things that Melanie was talking about, social economic development, you know, supporting in the broadest way. So I think that is very important. We've also got to make sure, and this is fundamental, we have to make sure that we've got the right data systems in place. It might feel like a nitty-gritty, you know, just operational thing on the side, but actually it is fundamental.
What about them?
If we can't interoperability, the right data infrastructure, digital infrastructure for every part of local services, because without that, you can't offer the seamless service that we are talking about.
Thank you very much. Deirdre Costigan.
Am I asking that?
Question 4. Yes.
Okay. Sorry, apologies, Chair. So just in terms of integrated care systems, so I think it's a question to Stephanie, really. They're supposed to, the idea is they would support long-term transformation in the delivery of health and care. And I know the Hewitt review expressed concern that that might actually mean they become a nice to have. And you mentioned there the sort of the burning platform, so the pressures that face the NHS. In that context, how can we support and how can we ensure that ICS leaders get that support to drive the shift that we're talking about into the community while they're facing all of those intense short-term pressures? And in particular, you know, how we drive work into sort of public health and preventative work.
Okay, so I think in a sense we've got a good start in the fact that the government has articulated this ambition, which is the first time it's been said as loudly and clearly as that. And the NHS is very good at doing what it's told. So if it is the priority of the government that there is this shift into community, then that needs to be followed up with what does that look like in terms of the kind of targets that government is setting for us as part of our planning. So I think if the government and NHS England support that through the planning system that we've got, then that will of itself drive that kind of change. And so in a sense that's some of the leadership actually that we're talking about, and that leadership needs to happen at all levels, doesn't it? Not just nationally but regionally and locally as well through ICSs. And actually everyone is up for it. In my system, everyone totally supports this agenda, and that's why we've recommissioned all of our community services with this as the focus. And picking up the points that Saffron's made about the contract, that's really important as well. And what we're trying to do is to make sure that our contracting is outcomes focused and that it's got the length of time in it. So our contract is 7+2. So the provider knows that they've got this contract for that period of time. They can put the investment in up front to do the transformation of services that needs to happen over that period of time, and so that they can get their return on investment. And we've guaranteed what the funding envelope looks like. That's the other thing actually that is really helpful, I think, across the board, is to have some kind of certainty of funding. So any sort of medium-term funding settlement is really helpful. I'm hoping the spending review will help with some of that, so that again you've got the certainty, you know where you're going to be, and you can plan for that. So I think those are some of the drivers that will help us to actually deliver that. I hope that helps.
Can I just come in quickly on that? So you mentioned there about the funding and the certainty of the funding, and this is in relation to it's a voluntary community and social enterprise, isn't it? I think that you're using, and I should probably say to declare an interest, I'm a Unison member, and I think Unison is one of the unions involved in the discussions on that.
Yes.
But just to go back to the point about funding, I guess if the kind of community stuff is being done in that way and is a kind of, I think it's an outsourced contract, isn't it? Is there any disincentive then for the acute services to take part in that shift of moving services and patients into the community? Does it then impact on their funding, on the acute services funding, in terms of the point you were making earlier about the fragmentation of funding?
It certainly wouldn't any time soon, because the acute services are absolutely overwhelmed, frankly, with the volume of demand that they're having to deal with. So I think anything that community services can do to help people stay out of hospital in the first place and to leave hospital as quickly as their treatment allows, I think they would regard that as really helpful. And certainly in my system, our acute trusts are absolutely supportive of the approach that we've taken in this commissioning round. So I think it's supportive. But Saffron may know more about that than me.
No, I think it's really important that we kind of think of this in a sort of paradigm shift. I don't think we're in the territory now of acute trust saying you're taking our business away. We're absolutely in the paradigm of saying we fundamentally need a way to be able to provide high quality care, to minimise risk, to encourage patient flow and to give people the experience that they should have. So that is absolutely about admission avoidance. It's about getting people, as Stephanie said, getting people out of hospital as quickly as possible. It's about anticipating their needs and stopping them deteriorating at all. I can certainly give the committee write to you and give you some examples of where this is working really well in terms of different places. Hertfordshire community in particular has got a fantastic kind of left shift programme where it anticipates. It's called -9. It anticipates what someone might need 9 days before admission and starts to look, it's stratified all of its population, understands who's at most risk and starts to look at what they need. So there's some great initiatives out there, but there is absolutely no sense from our acute members that community is out there prowling around taking its income away. It's absolutely about how we get really good flow, because really good flow enables us to move forward on the bits that are top of mind for the public. So if we think about 18 weeks target, if we think about all the constitutional standards, then that's top of mind for the public, that's top of mind for trust leaders, it's top of mind for everybody working in the system. So I would say this is wholeheartedly enabling and not undermining.
Thank you. We'll also come back to this point. Ben Coleman.
Thank you very much. Thank you. It's very good to see you all. And I just declare that the questions I ask are partly based on many years as being in a council and the cabinet member for health and adult social care, and also sitting on an integrated care board in North West London. So, given that, my experience, I just wonder if it reflects in your experience, is that for the NHS to achieve its objectives, it has to work extremely well with local councils, and we've been talking about that. And local councils, again in my experience, I'd like to know if it's yours, they understand the NHS rather better than the NHS understands them. And how much of a challenge do you think it is that the different parties don't necessarily understand each other very well, and how can we overcome that? Maybe I can come to Melanie first.
Yeah. So I think one of the challenges to integration is that we've got two completely different systems. So adult social care is in the main locally funded with local oversights. That's 153 councils delivering those functions. I'm talking from an adult social care perspective, but equally it's for any local government functions. And then we have our partners who do the housing authorities, so community councils and some district and borough councils. And then we have a sort of vast array of NHS organisations. And I would say that there's thousands of different ways that people work well and don't work very well locally. So that's my experience. There's some amazing examples of integration, positive working, a care home and a paramedic, or a community nurse and a social worker. And equally there's examples where leaders don't speak to each other and can't agree on a way forward. So I think there's a huge variation.
I understand that at the local level, individual services can work well, but at an ICB level, at a system level, and you come from an ICB which has only 3 councils, I come from in North West London which has 8. How much at that particular level is there an system understanding of local authorities and vice versa, and how much does this lack of understanding have an impact on what is trying to achieve?
Well, again, there's huge variation. So in my own system, I play a very active role in my ICB. I sponsor some of the integration work streams. We share intelligence, and we do feel like we have a seat at the table. But I think, unfortunately, that, like I said, we've got these two competing systems. So our financial planning and organisational planning systems don't align, and they don't align centrally. So I was asked the question, what can government do? So aligning our planning systems and financial systems would be really helpful. Both the local government system and the NHS is under huge fiscal pressure. We don't have the resources that we want to deliver the things we're doing today, so huge pressure, and that has led to command and control behaviours, particularly in the NHS, and moving us away from funding decisions that achieve our vision about the shift from hospital to community. So they're the sorts of things that can be tackled nationally to enable those things to happen. So I'm not dodging the question, but it's just huge variation. So when I talk to directors of adult services, some will say they got amazing relationships in their system. Some will say it's really difficult and tense. So that, like I say, lots of variation.
Thank you very much.
But we do often, the ICB I think is great in terms of ideology, but the practicalities get in the way. So things like having discussions about how we're meeting our duties under Section 117 in the Mental Health Act, where we have to jointly commission packages of care, the interface between continuing health care and the Care Act ability to place somebody, that these are real tensions because we lack in the resources to fund that, and these are really essential mechanisms to be able to support people well, to have a good life in the community.
Thank you very much. I see Stephanie wanted to come in on that.
So really just to reinforce some of what Melanie was saying, it really does vary from system to system according to the discussions I have with my peers across the country. I feel extremely fortunate that actually generally our relationships in my system are very good between our local authority colleagues and NHS, and for that matter the voluntary sector. On my board I have the voluntary sector on it as well.
The voluntary sector, what's the community sector? Because I was just looking at your board and that position's vacant at the moment. Is that because it's challenging to fill?
Yes, the person that was the board member left, and because of the procurement, we've left it vacant while we worked out what to do with that position. But getting back to your earlier question, this goes back to the point I was making earlier about the fundamental change in the way that we are now expected to work together, which is about collaboration and having the duty to collaborate. And this is something I frequently remind my board members of. But it's tough. Let's not pretend otherwise. It is really difficult. Everyone's under enormous pressure, and that inevitably creates tensions. But actually, you've got to have those difficult conversations because we all are working for the same community.
I'll probe you, because to come back to my original question, where are the greatest tensions? Either between different parts of the NHS which don't want to work or aren't used to working together, or are they between an NHS which doesn't understand a local authority and vice versa?
To me, there are two separate things there. So the lack of understanding, if you like, between the different sectors is probably present to some extent everywhere. And this is a challenge that I think we all face. And that I say to people, we have got to find out about each other's perspective and understand each other's perspective. It's your job as a board member to make the effort to do that as part of your role as a member of the ICB board. Interestingly, when I have seen people do that really well, it really makes a massive difference to the way that those organisations work together for the benefit of patients.
Just to follow up on that, that's very interesting and very helpful. You've appointed a private sector provider to bring together everybody and children's to do something new in the area of children's services. Is that because you couldn't get the skills locally, or simply bringing someone from outside who was neutral was an easier way of dealing with things, given that you've got three systems locally you're bringing together?
Nothing to do with it, I have to say. We ran a commissioning process, which is a procurement, so who ended up winning it was entirely determined by the process that we went through. So that was not a fact. It would be illegal for us to actually do that, to be frank. So that's just the way that it has ended up. They've won the contract. And of course, they're a company that's worked in our system for quite some time already, so they know the patch. That place on our board, now that you're asking me, I need to decide how we're going to fill it, because it is a privately owned organisation. I probably won't make them a full member, I will make them a participant. But I think it's important they're in the room, except when there is a clear conflict of interest, in order to be able to contribute to our discussions about how to achieve this shift. I hope that makes sense.
Very much. I don't know if you want to talk about how we can improve the understanding between the different parties.
I think there's something here about remembering that the variation point is really important, and so there is something about what we learn from where it works well. I would say that one of the fundamental elements there is both the longevity of relationships, essentially. So in places where if you remember how ICSs came about, they were created out, and in some places they naturally fit a footprint where people have been working together for a very, very long time. In other places, they were new, and so people were building whole hosts of new relationships. So they're building that trust. They're really seeking to develop that. So I think we need to remember that. I also think that, everywhere is challenged, but those systems that are perhaps facing additional challenges, whether it's kind of areas where rural sparsity of population, very difficult to get people to go and work there, coastal community, those kind of things make it even more challenging.
Thank you. That's very interesting. I guess I'd like to, I'm looking at, and I shouldn't, Stephanie, pick out your board, because there are, how many is it in the country now, ICBs? 42. And they all operate in their own sweet way. There are a couple of things I would like to bring out. One is the role of councillors, and something is about the Better Care Fund, because we talked about the funding. If I may just ask Melanie to pick up on that. The agony of, from the local authority perspective, of having to deal with the NHS coming in late, very late, deciding on the Better Care Fund and requiring changes at the last minute, it can feel simply disrespectful. Is that your experience? And do you think other people feel that?
I think the Better Care Fund is quite a small part of the money that both partners spend, but it has an extraordinary disproportionate emphasis, because it is something that I think has been there, and it is that point of tension often. So the Better Care Fund, like I say, is just completely moved away from purpose. But you're right, it's incredibly bureaucratic. The planning guidance comes out after the time we should have agreed it, so it then therefore means we can't do a meaningful engagement through Health and Wellbeing Board of Partners to look at the plans, because you're doing a retrospective authorisation every year. So it feels like a very difficult, like I say, bureaucratic and almost futile purpose, but it has lots and lots of levers and expectations on it.
It comes out so late. The NHS, all the local authorities are waiting for it, and they're waiting and waiting and waiting, so the local NHS partners, and it comes out so late. Is there something systemic in the centre that needs to change?
We need to review the way it operates and its purpose, and be very clear about that going forward. And because, like I say, over the time we've changed bits of it. So parts of it are protecting adult social care. There were bits of it that were to do with the Care Act, which we implemented 10 years ago. So those things have kind of got lost through the channels of time. But certainly it doesn't work. I think the key learning for me is it doesn't work for both partners. I think if you asked either local government or the NHS, they'd both be saying, in the main, it doesn't work. We've got examples of really great things we do from it. But as a mechanism itself, it's not fit for purpose. But I can't imagine why that it takes so long for the planning guidance. It would be unrealistic for me to say, because I'm not close to it enough to be able to comment on what they need to do to shift that. But I'm just commenting on the impact it has on partnerships such as Health and Wellbeing Board.
Which with other witnesses, we can come back to what the challenge is there. Would you mind me coming back, Stephanie? I'm sorry to put you on the spot again. Just to come back to the group that you've appointed to, as you just talked about, this new community care partnership. How you went and commissioned the services, but how difficult or how easy was it to get agreement among all the partners that you wanted to do that? And once the project's been, that you wanted actually to commission somebody to do that, rather than have somebody from within one of your local authorities lead it, as a commissioning exercise, why was that essential? And there may be very good reasons. And also, how are you going to learn from it? Is it going to be very clearly specified outcomes that they're going to have to achieve? I find in all of these things, specification of outcomes, which I think one or two of you referred to, often is lacking.
Okay, so we had to recommission these services because the contracts we had were going to run out at the end of March next year, so there was a timing issue, so we had to recommission it. We based the commissioning process on the care model that we had developed in consultation with some partners and with the public. Also on our integrated care strategy that the ICP agreed. Again, that was based on all the strategies from our 3 local authority places. And again, the consultation that had come through that. So we defined our 3 objectives for the ICP strategy, which is prevention and early intervention, tackling health inequalities and providing excellent services, and within that, doing this shift into the community. everybody agreed that that was the right thing to do. It was absolutely unanimous across all system partners. So the commissioning framework was based on all of that. What's interesting and innovative about the contract that we have now awarded is it is outcomes based. We've got 9 transformational priorities within it. I have the grid here. I'm very happy to share it with the committee. It's really quite interesting and impressive. So that was the process. We went through the usual process. We had to use all the public procurement rules and regulations, all the legalities, all the rest of it.
It's brilliant.
So
and that sounds very impressive. When it's done, how will you evaluate the learning? How will you share the learning?
That is all built into the whole thing. As you can imagine, this is of great interest to us, so we will be monitoring it, to death, actually. And so it's not just the ICB, it's the 3 local authorities, so it's jointly commissioned. We have a commissioning board and a governance structure that will monitor the contract and see how it's going. All of that will be in the public domain. So very happy to come back at a future date and tell you how it's going.
Final question, which I mentioned at Saffron, if I may, to you. It could be to anyone, this, but it's just about I noticed on some integrated care boards, you have a chair who's from a local authority background and you have a chief executive from the NHS. Others, you have both NHS. Some integrated care boards have councillors on them, cabinet members. Others have chief executives. Is there any particular model when it comes to NHS taking one position, councils taking another position, that seems to work best or seems to work least well in terms of, and which might be most helpful in terms of driving support care from hospital into communities?
I think it's a really interesting question, but I don't think we're actually seeing a difference in the nature of operation due to the different types of leadership. And I think I suppose I want to turn that on its head and say we know that different individuals will bring different elements to the table. So a council leader, perhaps chairing, or a councillor chairing an integrated care board, will bring something very different but really important knowledge to the table versus someone who is, an ex-trust chief executive running the whole shebang will bring their perspective, and when it is the opportunity for those two to meet. But I don't think we are seeing huge differences. We're seeing different perspectives being brought to the table, and I think it's undeniable that bringing that local elected representative voice to the table is really, really critical, just as having the operational nous is really critical. And I think, just like any organisation, it's about where you put that and how you use it. The skill is in the leadership of using the resources it's got, and people will have different backgrounds. Indeed, councillors have different backgrounds, don't they, and things to bring to bear when they step to the table. But all of those roles were competitive and interviewed for, so it's about, I suppose, particularly thinking about local areas and local patches and what they need and what individuals understand about them.
You're interviewed for, because I wouldn't think they're not all in local councils interviewed for. The council just puts out the person it thinks is best for the board. But
to lead, to be the chair of an integrated care board.
Yeah.
Yes, not necessarily those parts, but to be the chair or the leader.
Thank you. Thank you very much, Chair.
And I'll ask a related question about accountability. And I speak from my own local experience. I mean, there is a frustration in my trust that there is very little accountability, local accountability in the ICB. MPs raised, for example, that they were removing the place-based person for Oxfordshire. This seems to be quite unusual around the country. We'd written to them, we tried to meet with them. The local health and wellbeing board said that it wasn't the right thing to do, and yet they went on and did it anyway. And that's just one of many examples of MPs feeling that they try and, get in to these decisions and they can't, and a general feeling of a lack of accountability. How do we introduce this into the system? Because it strikes me that there is a democratic deficit in the way that ICBs are currently set up. And I'd love your thoughts on whether you think that would be a help or a hindrance. I hope we all agree accountability is a good thing, but if it is going to be there, how should it be there, and how could it be meaningful? And perhaps, I'll offer to Saffron Cordery to start, but if anyone has any other thoughts on that, I'd be very welcoming of them.
Yeah, it's another interesting question, and I think Stephanie may well have views about her own relationship with local politicians, because I think as an ICB leader, you will have your own relationships on your local patch. But I think certainly from a provider trust perspective within the ICB, I think that the core elements that trusts are ultimately accountable for is the quality of care within their organisation and the quality of care that they provide to their public. But I think they see themselves as very much embedded in the system and influencing that system as well. So they will prize their own relationships with local MPs, local councillors, in order to make sure that people are aware of what's going on, what the challenges are, what the needs are, but that doesn't necessarily need to be at odds with the broader structure within which they sit.
Who do you fear the most?
Who do trusts fear the most?
Yeah, who if someone came along and said, right, I'm going to come and have a look at you, which part of the system is it that you would fear that, what?
So I think I think that in terms of that accountability, I think there is definitely the accountability to the regulators, the quality regulators, the oversight that NHS England demands. But I think it's worth remembering that trusts also feel deeply accountable to their local communities. A trust will fear bad publicity locally. Trusts will fear the reaction that they get from their public. If you think about everything that we go through in terms of making changes to services, that's absolutely, that is where the real rub comes, and it's the trust's job to really convince the public that this is the right thing to do for the multiplicity of reasons that there will be. So I think, there are a number of accountabilities there.
If I may, Chair, on that question.
I think we need to. Can we move on to finances, if that's all right? Okay. Yeah, sorry, we've got to go on. Greg.
Yes,
Stafford.
thank you very much. I mean, I won't ask a question, but I will follow up on the point that the chairman has just stated. In my constituency of Farnham and Borden, I'm covered by 3 ICBs, and I can tell you the variation of quality in both the service delivery and, perhaps to the chair's point, communication and accountability between those 3 ICBs is extraordinarily different. And there doesn't seem to be anyone who is able to hold ICBs to account in terms of their overall performance and engagement. But moving on to the finances and following on from the question from Deirdre, this is to Saffron, and I just want to say thank you to your colleague Layla McKay, who's been in contact with me since I spoke on the same panel with her at the Conservative Party conference on these issues. It's been really helpful, so please pass that back. But I listened to your answer about essentially how you balance or how you ensure that moving funding from essentially the acute sector, from the hospital sector, into the community setting is one that's happening already and it's all okay. That's certainly not my experience of it. How do you ensure that actually you move that money and the funding and the resource without detriment to the acute sector?
I'm not sure I said it was okay. I think I said it was happening. And I think those are 2 different things. And you light upon a really important point, because what we're talking about here is transformation of how we deliver services. And there are a number of factors that come into that, whether it's pace, whether it's managing risk, or whether it's kind of the scale of investment. And I think we have to look at those, because you can go fast, but that could be risky. You could invest more and double run, but that will give you the pace you need. If you don't invest more and don't double run, then you need to do this more slowly. And I think that's some of the challenge that we're grappling with at the moment. The burning platform is there. We're all very aware of it. However, it's absolutely incumbent on those leading services at the centre and those delivering services, that we do this in the safest way possible. And we do know that issues around double running are tricky. I mean, we could, I don't want to, but we could go back into the history of kind of why we're here, and there are all sorts of issues, but I will highlight the fact that probably 10, 15 years ago, we made a decision to take out a number of beds in inpatient settings with the intention that we would build up the community side. Yeah. What we didn't do was put that resource into the community side, because what happened was there was a resurgence in demand for a whole host of demographic, population, public health, health inequalities reasons that meant that demand also shot up. And we see a gravitational pull towards acute. So I think that's really important to remember.
I think that neatly follows on to my next point, which is about political imperatives. Governments of all colours obviously have set targets. We see that, getting operations done, reducing waiting lists, etc., is a priority for the government, which is obviously all at the acute end. So, or a significant part of that is the acute end if you're talking about waiting list operations. So how does that help or hinder this, this ability or this aim to move things into community when all the targets the government puts in essentially is trying to funnel the money and resource back into the acute sector?
Well, I think in my opening remarks I made the comment that we need to see what contributes to our ability to get that waiting list down. And one of the things that really contributes to our ability to get that waiting list down is improved patient flow and improving, reducing the demand on acute services. And that comes from shifting resources from an inpatient setting into a community setting. It's, so we need to look at that aim from end to end.
And I understand that, and I completely agree with it as a policy position and how you'd work that out. But the reality doesn't seem to be matching that. So how do we break the kind of cycle where we say we want to do this, winter pressures comes up, waiting lists are going up, and whilst we say we want to do it, actually what happens is the money gets pulled to deal with the acute? How do we break that cycle?
We need to look at the reality of where we are investing, and we need to take on board that there are some raw facts that over the last 10 years, we've pulled money out of some areas that would have stopped us being in the situation we're in. So the public health grant, for example, is one where we have seen a huge undermining of the level of investment in public health. Public health is our tool for preventing ill health, and it sits alongside, public health sits in local government. From the moment it was moved into local government, that grant was pulled away. It was almost halved straight away, I believe. So it had a whole chunk of money pulled out from it, and that was about 10 or 15 years ago. If we had seen a gradual increase in that funding, we would probably be in quite a different place now, with communities and individuals physically and mentally much more resilient than they are. So I think we have to remember we're dealing with some of the consequences. In terms of answering your direct question, we need the political imperative and we need the operational leadership to be able to move us to a place that says, yes, we want to achieve this target, but we understand the steps that need to be taken to do that. And that's end to end. That's looking on stopping people going into hospital, and it's looking at how we discharge them quickly. And it's also looking at how we organise our services. So, hospitals are doing great things with hot sites and cold sites, protecting surgical units, hubs in the community, things like that, so that they can get through stuff faster. But at the end of the day, we've got finite resource, we've got finite workforce, and that's not elastic.
Thank you. And it's always nice to hear things of my former role in GIRFT being mentioned. So. Thank you, Chair.
Thank you very much. Paulette Hamilton.
Good morning. Can I start by saying I've got an interest because I know one of the panel members really well, Melanie. I worked with her for a number of years. She was my chief officer when I was a cabinet member in Birmingham. So
noted.
Hello,
Happy to facilitate the reunion.
Okay, right. So my question is predominantly for Stephanie and Melanie. And my first question is about The question is, there has been multiple reviews done, and these reviews have called for a move away from that single financial year settlement. Now, I know that this would have long-term impacts on the service from when I was in there, and we've talked a lot about prevention and moving away from analog to digital and all this stuff, but you need to have a more longer-term financial plan. How do you feel we could make this happen? If I start with Stephanie, because we're looking predominantly at ICSs and at local government. So, Stephanie, over to you.
Well, I can only really repeat what I've said earlier. Really, it's the financial settlement, maybe the spending review we've got coming up. If that can give us a very clear indication of what multiple year funding is going to look like, then that really does help with the financial planning for the future, really. And then that helps us to say, okay, that's our envelope, and this is what we need to do within it, and this is the challenge we've got, and how are we going to tackle that. So I don't know. Does that?
No, it doesn't, because as an ICS, you've got lots of targets, haven't you?
Yes.
You've got lots of targets. So you've got your funding, you've got your targets. So my question to you is, if you want to make a difference in the long term, yes, you've got the multiple in-year funding settlement, but what would strategically help you as an organisation to develop practices or to develop new services or to really move into that preventative space if you were able to have a longer term financial window, if that makes sense?
Okay, so are you talking about things like ring fencing and stuff of that nature, giving?
You tell me. Well, I've asked you the question, so you
generally
tell me
speaking,
what you think.
my view is that we shouldn't have ring fencing, because the way that the funding gets spent should be for local determination. Having said that, however, I do think it's really important, certainly in the short term, to protect funding for things like mental health and for community services. And I don't know if this is a true statement, but one of my views is that part of the reason we have separate organisations for community services and for mental health trusts is in order to protect those budgets for those kinds of services. Otherwise, it will get sucked into hospitals. There's this gravitational pull that funding just goes towards the acute sector, and that's obviously contrary to what we're talking about today, and it's not in the interests of the patients of the future. So I think possibly in the guidance that we get, government could decide to say X percentage of your allocation should be for mental health and community services, and if you're not going to do that, you need to explain why. I'm reminded of the recent example of where there was some ring-fence funding for health inequalities, and then the ring-fence was removed, and of course a lot of systems then just took it straight to the bottom line to help with their deficits, which is just, which I think is a tragedy. So I think it is really important. If we think things are really important, then there needs to be a strong steer from national government, from NHS England, I would suggest, that actually these things are important. It's critical to the success of systems, and therefore you need to make sure that those funding streams are catered for.
So, Melanie, as you know, the biggest thing my biggest bugbear in local government was that we only had like single-year financial settlements, and we struggled to plan ahead. And sometimes we would make that plan not really knowing if we'd got the funds to actually carry out, because we were trying to develop services and bring them forward. What would be? I'm going to ask you the same thing. How do you feel we could make this happen?
We do need a radical shift in our financial and managerial incentives. A really good example is that we set up integrated care systems, and then immediately there was a pressure on ICBs to reduce the leadership at place. Yep. And that's what happened. So many ICBs reduced the inequalities fund, the leadership at place, moving us away from that shift from hospital to community, because I assume that when we're talking about that shift, we're talking about a vision, we're investing in preventative, proactive, personalised care. That's a very different set of investment propositions than the ones that we currently have. So that would be the really important bit, would be to think about how do we do that. So we've mentioned some of those mechanisms, the ring fencing, protecting, whatever vehicle there is, that would have to be a bold political action to make that shift. If we're not going to do that, the shift won't happen in my experience. You've referenced the very good reasons why we struggle to align the planning cycle. So the NHS and local government settlement cycles are different, they don't align, the planning guidance doesn't align, and we referenced the Better Care Fund where that planning guidance comes out late. So aligning that mechanism and having a multi-year settlement would help, even if it isn't the whole of the financial settlement, but just the, like I say, that sort of programme budget, if you like, for what this hospital to community shift we want to see is, what was it actually we want to achieve. If we just had that as a multi-year settlement, that would support that. And I think we need to be really imaginative in how we use the policy levers to rebalance the investment from non effectively we talk about non-acute services, aren't we? Let's be honest. I know Saffron will have to take a more diplomatic perspective, but that's what we're describing. We're talking about community services, primary care, social care, voluntary and community service. So we need to be able to have those levers following that investment shift. The bit we really struggle with is moving funding that's allocated nationally to health care into other things that aren't the NHS. So whether that's public health, social care, community support, accommodation. So it's seen as an NHS budget rather than a health budget. So starting to see that as a different radical shift in our, the way we think about that resource would enable us to feel more comfortable about the money moving into other forms of support that aren't necessarily NHS-led, because in proactive personalised care there's a whole range of things we need to build around communities to make that a reality.
And do you not feel, I was just going to say before I ask my last question, do you not feel at the moment we're still very much NHS, going back to what Ben said, local government, and we're not doing that systems approach that will affect that change?
It's very difficult to do the systems approach locally with the national constraints, and we've, I think colleagues on the panel have rehearsed a number of those, not least the fiscal challenge and this sort of grip, whether it's in the local government or NHS nationally, to try and control demand, spend. And we know we're really up against it with that. And we haven't talked about some of those other barriers, the workforce strategy. We don't have one for adult social care. The data is really challenging, data and information sharing, really challenging. And there are some of those things that we could resolve nationally in workforce strategy and planning and data that would enable us to do that more effectively at a local level. Because I think we really need to focus on how we can enable local leadership, because you can't do national community care. And that's one of the paradoxes.
I'm going to get into trouble from the chair, so I know you were desperate to get in, Saffron.
I think it's really important when we're thinking about funding and funding allocation to think about what we are seeking to do. So funding community services of whatever type, including mental health services, is critical in and of itself to deliver the right kind of care. I think if we see the end of something like the mental health investment standard right now, what we will see is the marginalisation of people with severe and enduring mental illness. We will see more crises turning up at our A&E departments. We will see more challenging situations which impact not just acute care, they impact the individuals themselves who are suffering, but also impact across other bits of the public service like the police, education, etc. So we need to make sure that we're building on some really good progress that we've made to continue that and build that into the funding framework. Funding services in the community, funding mental health, funding social care, funding primary care are steps in and of themselves to shift the demand, but they are also important to provide the right kind of care that people need.
Yeah, thank you for that. Am I allowed to ask the last question or
30
not?
seconds.
I'm done. 30 seconds. Well, I'll do it this way. I've got one more question. I'm going to ask you to give me 1 point, Stephanie, and 1 point, Melanie. That's the only way I'm going to get away with it. So the question is, how could the government or the NHS England better incentivise ICBs to invest and to deliver and to prioritise services in the community? One thing that you think could help?
Include it in the planning guidance and measure what we're doing on it.
Fantastic.
Thank you.
I would agree.
On that note, can I hand back to the chair?
May I thank all three of you sincerely for being here today. You gave us lots of food for thought. You are very welcome to stay for the second panel. And thank you again for being here. Right, if we can quickly turn the panels over, and we will move to the next hour. Order. We now come to our second panel. Thank you so much for being here. We're going to be looking at workforce and structures and all sorts, and build on the very excellent first panel. So may I welcome all three of you to our session today. If we can start with very briefly introductions, so perhaps starting with Beccy Baird. Thank you.
Hello, yes, Beccy Baird, Senior Fellow in Health Policy at the King's Fund.
Thank you very much.
Nicola, Chief Executive and General Secretary at the Royal College of Nursing, previously Chief Nurse for 10 years in acute trusts.
Thank you very much.
I'm Kamila Hawthorne, I'm Chair of the Royal College of GPs under Working GP.
Lovely. So if we can start with something very topical. So we've had the announcement from government of the 2.8% pay rise, which I think it's fair to say, Nicola Ranger, you were sceptical about this morning. May I ask, first of all, just in the context, you've said you want talks with the government. I found that an interesting statement. Have there not been talks already? Are you not talking to the government?
We absolutely are. I think that's why there was genuine disappointment, because we can see, I think, that this government is very genuinely interested in the NHS. And I think we as a college absolutely believe in the priorities, particularly the shift from acute to community. But there's a golden thread here that has to make it absolutely essential, and that's workforce. And the largest workforce for all of this, whether it's community or acute, is nursing. And in England, we still have 32,000 nursing vacancies. We are incredibly reliant on international nurses, which of course, while we absolutely welcome our colleagues, we are destabilising the rest of the world with regard to their nurses. And what I'm disappointed about is there's still been no structural reform of nursing in this country, which I think, and we feel as a college, is an extreme disappointment. It is no longer just about a percentage pay rise. Nursing in the UK has got so many challenges that will absolutely not work. There's been a decrease, 21% decrease in people coming into nursing and those leaving. And I've listened this morning with real intent, but the underlying conversation that wasn't mentioned is exactly as you said, workforce. Without nursing, whatever the government wants to do, it will not be able to succeed. And what we're disappointed about is that there's still no structural reform for nursing. And that is going to make it very difficult for this government to achieve. That's what we want to talk about. It's no longer just about a percentage pay rise. It's what are we doing, particularly in England, to make sure that we both retain and recruit brilliant nurses in every single sector. And that is what we're disappointed about.
I mean, this morning you mentioned it in the context of we need to avoid talks to avoid further disruption and ballots. And I think there's an acceptance in this place that the disruption and ballots that we've had over the last few years, just, understandable as some may feel they were, have also played their part in increased waiting lists and stresses on the system as a whole. what's the better way of ensuring that these conversations take place without that further disruption? I think as a committee we are very mindful of the stresses on the profession at large. Isn't a ballot and disruption just going to make it worse?
No one wants that. It's always a failure on both sides when it gets that. But you cannot have 10 years of real underfunding, the least amount of funding for the NHS in its entire history for nearly 10 years, then go into a pandemic, and then not wonder why we're in a very, very difficult position, which we are. And the people that suffer most for that are the patients. But let's be really, all the things that were talked about this morning, when you have got extra patients on a ward with no oxygen, no suction, no called gabelle, no privacy, no dignity, extra patients in a corridor in A&E, that's not a great place for professionals to work. And that is, in the end, also making people feel, can I do it again? And the real disappointment, whilst I absolutely understand the timetable of trying to make sure that there's a pay award in April, for many NHS staff to hear this right before the winter, when they've already escalated all over the place in acute hospitals, and district nurses seeing 26 patients a day on 15-minute intervals, which is a group of district nurses I met the other week, a few months ago. It's not going to make people feel great about another winter. So no one wants it to be difficult, but there is something about at least giving some kind of hope for the future, recognising the real financial difficulties. Because if we don't invest in the workforce, I think all of us really worry about the future. Patient satisfaction, the lowest in NHS history, and more people seeking private care than it's ever been. So it's on all of us to make it work. All we want is a plan. And at the moment, certainly for nursing, we've had no structural nursing plan to see how is it going to get better in the future.
Well, we've got West Streeting in front of us next week, and I'm sure he's heard what you've had to say. We'll come back to the GP's point later, because I do appreciate this is not just an issue that nurses are facing. Very briefly, Greg.
Yes, we can have a discussion, about, because the NHS has, in real terms, has had more money than it ever has had. But I'm interested on the funding point. Obviously, what you're talking about for nursing is agenda for change. Now, it's not just nurses who are on agenda for change. Would you include, so obviously there are other professions like the allied health professions, but there are also, let's be frank, all the managers in NHS England who are on agenda for change. Would you see a benefit in disaggregating or separating the pay streams or band or streams for what one might call the professionals, nurses, allied health professionals, etc., and the management side?
I think the college, recently put out a separate pay spine. And there is something around nursing generally is weighted to the bottom of that agenda for change. So if you're a band 5 nurse, you could have years of experience and your pay never go up. And inevitably, to get more money in the NHS, if you're a nurse, you sometimes have to move that little bit further from the patient. Whereas I think what we put forward is a bit of a difference between promotion and pay progression. So I spent several years in America where they will absolutely incentivize pay progression for those closest to the patient. The experience for the patient is absolutely outstanding because you get absolutely brilliant nursing care from someone who's got years of experience, but they can earn $100,000. And the difference to patients is enormous. Nursing is 62% of the band 5s is nursing. We're the only ones that will start as a band 5 and retire as a band 5. The only one. You wouldn't find a manager, you wouldn't find any other allied health professional in reality that will both start their career and end. And that is something that has to be corrected. And when shifting from hospital to community, we need an incentive that's different, and it's not just a percentage pay rise. And that's the disappointment, Chair, is that it's so fundamentally broken. England's the only place that you have to pay your tuition fees. Northern Ireland, Scotland and Wales, you don't. That has not worked. treating nursing as regular students because of all the practice hours. So that's the kind of thing I'm disappointed about. Yep. Because this is not just about a percentage pay rise. What is this government, who I absolutely believes in the NHS, as do we as a college, but where's the structural change that will genuinely make things better for patients? And at the moment, can't see it.
Thank you very much. So, thank you. And we're touching on themes that we're going to come back to. And before I throw the next question to Andrew George, I just wanted to ask Beccy Baird, who's done, the King's Fund has done quite a lot of work in this space over the years about the lessons learned. And so I just wanted to ask you the same question I asked the first panel. As we move forward with this 10-year plan, what are the key lessons learned for what we have to ensure happens for this shift from acute to community actually gets followed through on? What insight can you give us, Beccy Baird?
Thank you. So we published some work last year looking at why we haven't achieved this over the past 30 years, and it's complex. If it was easy to do, we'd have done it. I think for me, we are, just after Christmas, we're going to publish some new work looking at what national policy levers are available to government to make this happen. So I'm slightly preempting that work here. One of the keys is focus and political leadership, because the system will do what the system is incentivised to do. And if we say we're going to move care close to home but incentivise improved care in hospitals, we will focus on improved care in hospitals. Both of those things are important, but I think government might need to think about a review of the constitutional standards and how quickly they are likely to be achieved in this Parliament, because it will be very hard for the system to both achieve all of the constitutional standards for waiting times and deliver care closer to home. So political prioritisation will be absolutely key, and I think that's probably the number one for me. In short, I think as workforce is key, again, the way in which we incentivise the workforce to move in community, we reward people who work in hospitals because we pay managers by the size of their budget. We pay clinicians want to work in acute hospitals. We don't attract the best clinicians and managers into the community, partly because of the pay, as Nicola's talked about. We don't train people in primary and community settings. The NHS management training scheme doesn't have routine placements in general practice, for example. Lots of things we could do to really incentivise, but the key for me will be keeping that focus on primary and community services, because the minute we prioritise hospitals, that's what we will do, and we will continue to see what we've seen for the last 30 years.
Incredibly helpful. Thank you very much. Andrew George.
Okay, so thank you for your earlier remarks. Nicola, just very specifically on the point about band 5 nursing, and just for the benefit of the committee, what pay is that at the lower and higher?
That will start at about 28,000.
28,000. So that's 28,000 for a fully trained clinician.
Yes.
With a degree level.
Yes.
And just on the issue of the longer term kind of workforce planning, and this I suppose might apply also to Kamila as well. Just in terms of trying to achieve larger numbers within the service to achieve the 32,000, to fill the 32,000 vacancies and so on. Obviously, there's been a move towards, one might say, a clever move towards finding other ways of recruiting nurses, such as nursing associates and apprentices and so on. I mean, is that a clever move, or is it dumbing down standards? And is that actually a way of filling the gap?
Nursing associates, much as physician assistants with GPs, there is, and medical, there is something about substitution. So there's a concern with regard to that. But I think apprenticeships as a pathway, we have genuinely no difficulty with the route in, as long as it is a degree. At the end of it remains a degree-educated profession. What's not always understood, though, is that the apprenticeship route is a great route, but there is still a cost to the organisation, because it doesn't cost the entirety of their backfill to go to. So that still costs most trusts £18,000 per nurse. So whilst the NHS workforce plan talked about large-scale incentive, until that's funded, that still is a cost to the organisation, and that's part of the difficulty. If the apprenticeship levy, particularly for the NHS or nursing, could actually fund the backfill cost, the difference that would make, and if there was an exception made for nursing, that's the kind of thing that would make a difference, which currently you have the same as every other apprentice. But there is talk about taking it away at level 7, which would be a disaster for nursing. So I would urge this committee.
Level 7, explain, sorry.
So that would be, so for a nurse, because it's a slightly more degree-educated apprenticeship route, there's question about whether that funding is going to move to slightly more, diploma and others that isn't degree. But if that gets changed, then that will also make it harder for nursing.
Right, okay. And in relation to next year's review of the long-term workforce plan, I mean, there's an opportunity there for you to presumably have a big say in the review and to put a lot more emphasis on retention as well as recruitment and to address those issues. And maybe start with Kamila.
Got a lot to say about that. Yes, thank you.
Maybe you would like to use the opportunity of the review of the long-term workforce plan as your route into the subject.
Thank you. So we were delighted to hear Wes Streeting talk about a review only a few days ago. A few weeks ago, we sent in a letter that had been signed by nearly 10,000 of our members urging a review of the long-term workforce plan. The National Audit Office, having looked at the modelling, could see that the numbers of GPs projected to rise by the mid-2030s was 4%, whereas the numbers of hospital consultants, as you probably know, was 49%. And, despite the fact that the number of GP trainees was going to increase by 50%. And so when you look at it, you think, well, 2 and 2 is not making 4. It took us a while to get to speak to the authors of the long-term workforce plan, which we did a few months ago, and it became very clear that within their modelling they hadn't included retention. And we said, actually this is crazy because you've got a sink with a tap that's full on, but no plug in the sink. So people are leaving the profession faster than they're entering it. And we're still about 100 full-time equivalent GPs short of where we were in 2019, while we've got an ageing population with more chronic illness and bigger numbers. So when I first qualified back in 1988 as a GP, the average was about 1,800 patients per full-time equivalent GP, and now it's 2,300 patients, and they're sicker than they were back then. So there is, we're pleased that there's going to be a review. We need to get in there. We're urging for a national retention scheme with local flexibilities. What we're seeing is that GPs are leaving at all stages of their career progression. New ones are emigrating, mid-career ones are leaving early, and late career ones are leaving as soon as they can. And the reason behind all of that is workload and burnout and stress. That is really the bottom line, although there are, of course, different personal factors for everybody. So, and there are different retention schemes that are needed at each stage. And what we really want to do is to try and retain some of our older, more experienced GPs so they can mentor the younger ones, and bring them in and show them the joy of general practice, because it's a fantastic career when you get a chance to do it properly.
So retention is clearly a very important issue. Finance to enable retention will be a big constraint. I mean, are there actions which the government can take or the system can take to address retention matters without it becoming a large financial burden on the government?
So at the moment, money for retention schemes was available, and it was announced at the beginning of the year that it was going to be withdrawn by the end of March, which really upset us. So these are new to practice fellowships to encourage young, newly qualified GPs to get settled into a practice, get their feet under the table, understand what continuity of care really means, etc., develop their own professional interests. Well, those schemes, the money for that was devolved to ICBs, and as we've heard, that was not ring-fenced, and it's disappeared into a black hole somewhere else. So it's very, very patchy. There are some places where it's happening, but many places where it isn't. And the same thing has happened for mentoring schemes, and we actually need to be thinking about an emeritus GP scheme so that we can encourage some of our older GPs to stay on. We need more flexibility in the way in which people work, because that is what the workforce is now asking for. Yeah. They're not willing to work in the way that I was working 36 years ago.
But in order to achieve the shift from acute to community, which is obviously a mantra that's been going on for decades, and in order to be able to deliver that, the assumption is that its social care needs to be beefed up to be able to address the discharge issue, the delayed discharges from hospital. But in fact, actually, as far as I can see, there's a large number, a large proportion, indeed in Cornwall, where I represent, the majority of cases actually have an ongoing medical, a need for medical oversight. So, I think the RCN has put out a figure showing there's been 45% reduction in district nurses in the last 10 years. How can the community sector actually build its medical capacity with that level of failure to retain staff?
Absolutely right. And it's for school nurses, it's down since 2009, 31%. Learning disability nurses down by 44.9%. And health visitors, which are so key, down by 31% since 2009. So you're absolutely right. So that's where I think the long-term workforce plan needs to really look at what the issues are. Yes. And there is something about incentivising or finding a way to actually make that shift from hospital to community. And it's something that now sounds very, very operational. And I hope it's not too low level, Chair. But I think there's something really important practically, that the public it's really tough for them to understand when someone's come into an acute hospital setting. If your husband or wife has just had a massive stroke, in your mind you're thinking that's a healthcare need. So it is the patient's and family's right to have that need assessed. That can take up to 28 days, and that's one thing I'd ask ICBs to look at the data, is how long is it taking them to get their continuing health care need assessment done, because that's 28 days in an acute hospital setting. And actually, we often know as nurses, they're not going to meet that threshold. So for a family, that's now means tested. If they got over £23,250 in either assets or savings. It sounds a very practical thing, but the impact to families is massive, because they do not understand the system and think, how, when it's a health need, in their mind, can that possibly be means tested? All of that goes on in the acute sector. And on many places, up to a third of patients in the acute sector could be cared for in another setting. So things like discharge to assess, that all requires funding shifts, because we're never going to do what we need to do with the constitutional targets that are right for patients unless there's a genuine understanding from the public point of view and changing the way those assessments done, the funding. I went to a ward recently in the south of England where I met a patient who'd been in hospital 4 months. When I asked the ward, 26 out of their 28 patients on the elderly care ward had been there over 4 months, primarily because of funding issues. So this is a real and practical problem that's got to find a way to get sorted.
This is perhaps a good moment to plug our social care, the cost of inaction inquiry. And for those watching, today is the last day that they can submit evidence, although we're keen to hear from anyone. And thank you very much for that, because the impact on families and their carers is something that we're keen to look at, as well as the financials and the economic side as well. So thank you very, very much. Josh Fenton-Glynn.
Thank you, Chair. So first question for Professor Hawthorne. What support do GPs need to do more work in the community?
We need more GPs, essentially. We don't have enough. if you're on call, for example, you may have between 50 and 70 patient consultations in a day, and it's really not safe. Quite a considerable number of our GPs from our surveys are telling us that they feel it is unsafe, and that they are having real symptoms of stress and burnout as a result. So that's the first thing. The second thing is going to be infrastructure. We are going to need better premises than we currently have. I know that's going to cost money, and I know that the whole conversation is about how do we keep within the same envelope. But again, there is going to be a need for that, particularly if we're training more. More and more people need to be trained in generalism, and the best place to do that is in general practice. And that's not just medical students and GP trainees, it's nursing students, it's physician associates, it's clinical pharmacists, it's all, the whole raft of the team need to come out into general practice, and we don't have the room to train them properly, nor do we have the trainers. So those are the two big things. As GPs, we're absolutely up for these 3 shifts that West Streeting is talking about. People have been talking about services coming from hospital into community for decades, and of course some chronic care, a lot of chronic care now with the old QOF system, that started about 20 years ago, has come out into the community, but resource hasn't really been following the patient, and I think it's going to have to follow the patient for this to be done properly. And the other thing that we're going to need some sort of shared data for patient care, because otherwise I don't know what my pharmacist in the local pharmacy down the road has said to somebody, and they don't know what I've said to them other than what the patient is saying to them. And the same for the local optician, the local dentist, as well as being able to see if somebody's been to out of hours on a Saturday night. I need to know straight away what's in their medical record and how it's been dealt with. So that's another. Yes, I could carry on. There's quite a lot of things that we need, isn't there? But I think those are the 3 main things. It's about infrastructure. It's about more GPs, and of course more members of the primary healthcare team. So I completely agree with what Nicola is saying. And if we really want to do prevention well, we need to have the headspace to be able to do that, and then the ability to share patient records.
Thank you. So just to follow up on that, the State of Medical Education and Practice report that the GMC do every year came out at the end of last month. And I think one of the most alarming things in it is the rise of the doctors that are ending up in kind of SAS and LE roles. So I think it's gone up from 23% to 26% of the workforce, so about a quarter of the workforce, which are primarily hospital roles. What do we do to get those doctors on a GP training pathways? I'm not sure if that's for Professor Hawkins or for Beccy.
Well, it's a difficult one, because some of this seems to be also within the society of resident doctors, as they're called now. It's part of what they're expecting to do. They finish their foundation posts, and some people want to look around for a bit. Some people go down to the Antipodes, and nearly all of them come back, thank goodness. But that seems to be, as people are trying to work out where they want to work and what specialty they want to work in. But on top of that, there are some real bottlenecks in postgraduate training, and so some people can't get onto the training schemes that they want to get on, so they hang around doing bits and pieces.
Can I just interrupt? Is that they can't get into the training scheme in the area that they want to, or they can't get into the training scheme for the specialty that they want to?
Both, and it depends on what the specialty is. So some specialties are much more difficult to get into than others, so it's a bit of both. Yeah. For general practice, again, there is a bit of a bottleneck as well, not as bad as in other specialties, but certainly what we're also finding is that we're having large numbers of international medical graduates coming in too, and we're very grateful for them. I mean, they do a fantastic job, but we need to treat them well and value them well as well, which sometimes isn't as good as it could be.
No, absolutely not. So the other thing that came out in that report was just the huge levels of dissatisfaction with GPs. I think it said 53% of GPs were dissatisfied with their work. And obviously it's not sustainable. I think when we had Andrew Dillnott here a couple of weeks ago, he said we have to train 2 GPs to get one person in practice. I guess you've hinted to... Sorry. I meant
Darcy.
Darcy, not Darcy. I was thinking...
Later, another time.
I was thinking reports. I guess, I mean, you've hinted at a lot of these things about getting the GPs kind of the services better, but more generally, kind of what would be the top 3 things we could do to improve the satisfaction that GPs feel?
So I think the real problem underlying it all is stress and burnout. So it is, I'm sorry to be repetitive, that we need more GPs. Every practice needs more GPs, including my own. And some practices have real difficulty recruiting them, not just because there aren't GPs to fill those shoes, but also because they haven't got the core funding to pay for them. And that has been a real problem because over the last 10 to 15 years, the proportion of the NHS budget coming out to primary care has just gradually gone down and down and down, while the workload has gone up and up and up. So I think, there's a real issue there with, being able to pay for GPs to come into practices to work. There's also much less locum work than there used to be before.
Thank you.
Thank you very much. Jen Croft.
Thank you, Chair. So, Becky, you fairly aptly said at the start that the system does what it is incentivised to do. How do we incentivise NHS providers to effect that shift from hospital to community care?
So I think there's a few things there. One is this is not just about shifting care from one place to another. It's about shifting the focus of care. Sometimes it is appropriate to shift things from one place to another. Actually, more I think, as Nicola and Kamila have both alluded to, this is about shifting the focus. So the proportion of the money spent on primary care has gone down, and yet activity has gone up. That can't be right. So part of the incentive is just to rebalance where we're putting particularly new growth, any new money, where are we investing that money? I am very wary of microfinancial incentives. As a nation, we rely on them hugely compared to other countries, particularly in general practice. We have, with QOF, with IIF, all kinds of 3-letter acronyms for funding. But the danger of all these small disconnected pots of money is it stops practices and communities being able to really address the needs of their patients. So we saw it with the additional roles in general practice, fantastic scheme that's put loads of extra workers into general practice. It's a wonderful thing. But if we don't also fund core general practice, you end up with a really unbalanced team, because you've got these people come for free through the additional roles in general practice scheme. So we'll have more of them, but we won't have the GPs because we don't have the money to pay for the GPs. So for me, I'd much rather see a much more devolved system which trusts general practitioners to use the money that's given to them on a capitated basis, and they're held accountable, as are the local commissioners. And I guess that brings me on to another thing. If we're going to really incentivise the system, we need people within the system to keep an eye on it, to do the commissioning, to really think about how we invest in primary community services. And at the moment, integrated care boards in most places in the country don't have very good infrastructure at all for holding primary and community services to account, or for doing the strategic planning that's necessary. Their entire focus is on hospitals and emergency care because that's what they're judged on.
I've got 2 things to add into that as well, so thank you, Becky. The first being that I think that we need to have a louder primary care voice at the top of the ICBs. It's just not enough. There may be somebody from primary care, but it may not be a GP. And I think we need a stronger voice so that ICBs actually understand what's happening in primary care, because I think quite a lot of the time they don't. And then my second suggestion, which is a recommendation I'd like you to make actually, is to introduce a general practice investment standard similar to the mental health investment standard, so that ICBs have to report on an annual basis the percentage of budget that's coming out into general practice, and that should be increased funding year on year over the next few years to get us back to where we were some years ago.
And I'd like to see incentive to really genuinely get this right, that services that are offered in the community are 24 hours a day, 7 days a week. We can no longer have a model that's 9 to 5, because otherwise the acute sector will continuously be the catch-all, because it's the only thing that's open 24 hours a day, 7 days a week. So when you commission community care, make it 24/7, and you need the workforce that can do that.
My sort of question on that is, so moving away from kind of micro-budgeting or ring fencing, is almost how do you get that financial incentive in place that achieves the aims you're after? So GP completely escaped investment standard, for example. Are you saying you have the budget that goes directly to GPs and then it's up for that to spend? Or is the GP investment standard almost again having a ring fence budget given to an ICB and saying you must spend it on this? Are you looking more to, are there mechanisms where is the perfect balance between this is where you must spend money versus over to you kind of thing?
Yeah, and I think every country certainly every OECD country, every EU country is looking at exactly the same issue. What are the right payment mechanisms? How do you do the incentivisation of this kind of shift? I think there's a combination of things. One is we collect a lot of data in the health and care system. I think we did an analysis of community services a few years ago where we found there were more targets than staff in most community settings, something like 4,000 key performance indicators. And yet, what are we doing with that money? I think I'd much rather see, we know that good community services, I think somebody said it before, earlier in the session that I was listening to, you can't nationally prescribe community services. It just can't work like that. Every community is different, from Wigan to Fleetwood to Frimley to we see it all over the place. So giving a budget down to a place, down to an IC, and commissioning services for that community makes sense. Having good outcome metrics that hold them to account for what they're delivering with that, but allowing them to decide how they use that money to deliver the care. I think that the interesting thing about the mental health investment standard, a community investment standard, a primary care investment standard, is that kind of overarching proportion. So can we say you need to maintain the proportion or increase the proportion of money that is going into those services compared to the acute, because we know that the balance is wrong at the moment. But rather than saying you must use this money to fund X, Y, Z, very, very prescribed, specified services, I think trust in the system has disappeared a little. I think there's a definite sense that, we won't fund general practice too much because what if they don't spend it right? What if they don't do what we want them to do? What if they do wrong things? But actually, people in the health and care system want to do right by their patients. The people who know what patients' community needs are largely the people closest to them on the ground. So giving them the flexibility to deliver what's necessary, but holding the ICBs and having the people within the ICBs to hold them to account is absolutely critical.
Who is that? What does that look like? So
it's commissioning staff, essentially. So we did see without willing to dredge up history, in 2012 we lost a lot of capacity for primary care commissioning, particularly because it went from CCGs weren't allowed to commission primary care because of a perceived conflict of interest. It went up to NHS regional teams. A lot of the staff left, and in many places that capacity and that expertise in primary care hasn't been replaced. ICBs have seen 25% headcount cuts, and so what they focus on is what they're judged on. So they have people who are expert in waiting times targets and performance management of acute hospitals, because that's where the focus is. And they haven't. There are exceptions, and there are places who do this really well. But it's essentially good strategic commissioners who really understand how to do good community engagement, who understand how to commission services.
That's the strategic commissioning bit. And what about the accountability bit?
I think again held the same way. Sorry.
Can I come in with just an example then, which I think might be helpful? So LLR ICB, so that's Leicestershire and Rutland, they've been using their health inequalities pot, which isn't a very large one, but they've been distributing it to general practices in the most deprived areas of their ICB. This has been happening over the last 2 or 3 years, and they've allowed those general practices to use that money the way they see best. And what's happening is that access is improving in those practices. So it does produce improvements, but there has to be an element of trust and leeway so that people can be flexible in what they do and how they do it.
It's sort of, I guess, removing some of those strangleholds on services. My question really, I think, is just trying to get to How do you stop ICBs from being tempted to that acute sector when it's very pressing and is very noticeable?
By having some strong primary care voices up at the top, on the top table.
Well, I think that's definitely important, and I think, if you think about an ICB board, there'll be a chief exec from every hospital trust in the patch, but there won't be a GP from every practice, because that's not how it works. So how do we think about representation? But I equally think it's about the messaging that comes from national politicians, from national policy makers, from NHS England, from the Department of Health. Is what they signal is important, is what the ICBs will focus on. And if they signal that primary community services are important, that's what they'll focus on. But they can't also signal that waiting times are important. As important, you can't prioritise everything, I think, and at some point, some hierarchy, some conversation with the public about trade-offs will be really key.
Thank you.
Thank you very much. Robertson.
Thank you. I'll direct this, I think, to Professor Hawthorne, if I may. How does the GP contract need to change to better support a shift from hospitals into the community?
So this is really a question for the BMA rather than for us in our CGP, where we are upholding professional standards. However, it is quite clear that funding for general practice has been undershot for some time now. And so my call would be for the government and the BMA to get together and sort out the new core contract going forwards. We need to, within that, also create an ability to make an account for deprivation, because what we're seeing is in deprived areas, practices are working with more patients with more serious chronic illness, but actually able to earn less according to the targets that they're being set. So that's a real problem that needs to be sorted.
It sounds like it's more a funding thing rather than a change in the way we contract and commission.
Well, we're obviously thinking a lot about the QOF system, which I think has now run its course, and it needs we need different incentives now, perhaps including some sort of quality improvement type incentive on continuity of care, because again, we know that good continuity of care keeps people out of hospital, it reduces morbidity and mortality, it improves compliance with management plans, as well as patient and professional satisfaction. So, what's not to gain, really? So I think we do need to be looking at the old QOF system as well, reducing bureaucracy and red tape as we go along as well. So again, giving people the headspace, because we are going to need a lot of headspace if we really want to be thinking about preventive services and how we develop prevention.
Becky Baird, do you want to jump in on this point?
I'll make a couple of extra points if I may. I think there's lots of opportunity for reform in the general practice contract, but I would also think it would be very important to think about harmonising across the different primary care contracts, and by that I mean particularly the community pharmacy contract, because at the moment there's lots of competing incentives, financial incentives for pharmacists and general practitioners chasing the same money for the same, and that makes no sense at all. So I think some work to do to harmonise those two contracts feels important. Absolutely, deprivation is not well reflected in the formula, but estate reimbursement is one thing I would very much urge the committee might want to have a think, if you get time to think about primary care estates. It's not just about extra funding for primary care estates, which may well, of course, be needed. There are also some arcane rules around estates reimbursement and the way we're allowed to flexibly use general practice, which I won't go into because it's
take a long
entirely labyrinthine.
Noted, we'll go and do some homework. Yep.
And I think it's important as well, the investment that the GP can put within their practice in workforce like senior nurses that can do some of their patient interaction, freeing up the GP, and it's extremely difficult for many GP practice now to invest in that senior nursing support within their GP practice.
And that's again partly because of all these small linked pockets of money or not linked pockets of money, so they're chasing different bits of different pots of money for different things rather than having an overall budget.
And the nurses in the GP practice get paid less than the NHS, so it's really difficult to incentivise nurses to come and work with GPs over time. So all of these small things add up to a difficulty for the GPs.
So if you're really looking about messages that go out to the health profession, the recent budget message that $1.5 billion was going to be invested in hospital infrastructure and 100 million for 200 GP practices. That's only 3% of the 6,000 or so GP practices we've got in England. That message doesn't land easily because it implies that, again, it's the acute care sector that's getting the lion's share.
Paulette Hamilton had a quick supplementary, and then I'll come back to Joe Robertson.
You sure?
Yeah.
Right, sorry. My question was going back actually to the point that you made earlier, Nicola, about the RCN and the problems within the nursing profession. I've been a nurse for many, many years, and I actually was a district nurse, and I actually chose to leave the profession and did it consciously because I couldn't do it anymore. It's as simple as that. Last year, I was quite upset when the nurses gave up, when they did give up, because I shouldn't have said this, but I did back them all the way. This year, you've rephrased it and you've said, I know you weren't in charge of the negotiations or anything last year. This year, you've now said that we need to look more at the workforce and changing the way things are done. Why do the nurses need to go on strike to do that? Is it, I understand about the finances, but are you striking because the finances are not enough and the nurses are saying we want more money, or are they talking about striking because they don't feel the government is listening relating to how nursing is run at the moment and how it wants to be developed in the future? Because I just wasn't clear, to be honest.
Yeah, just to be really clear, we haven't said we're taking strike action.
Okay,
neither have we had a ballot. What we're trying to say is exactly as you've said. I have met Secretary of State several times, and I genuinely believe there is listening. So there is an understanding that nursing needs to change. The difficulty we had, as we know, with the 5.5%, we were the only professional and body and trade union where our members at 48% said this still isn't right for nursing. We're rejecting that. All we're trying to say is avoid that. No one wants strike action. Not us, not the patients. What we're saying is all of this shift from hospital to community, your point about district nursing, whether it's acute care, whether it's mental health, without nursing, nothing will work. And at the moment, 1 in 5 nurses in the UK, 30% of the UK register is nurses that have been internationally educated. And as I said, that's absolutely fantastic, they're here. But what is the long-term support for an amazing profession, which you know yourself, nursing's an amazing job, but people like yourself said, you've got a stage where you can no longer do it. People still love nursing. It's the environment in which they are being forced to practice. We want to support this government, but we need something tangible to go back to our over 500,000 members to say, nursing is valued in particularly in England, and we're not saying that at this moment in time. We're talking, but we need something more than talking. We need action, particularly in December. Everybody knows winter is going to be difficult. We need some hope, and we need some hope quite urgently.
Thank you. Thank you for allowing me.
Yeah, just coming back to that sort of incentivisation. I mean, I'm concerned that with sort of public understanding that healthcare and NHS are used interchangeably, and that you mentioned nursing. Of course, it depends on the setting, where you are, and who employs you. And there is an issue with governments, of successive governments, sticking with some very simple messaging around money for the NHS. And that is always an attractive way of presenting and budgeting. And it leaves GPs, pharmacists, etc., dentists, in what might be called the funding slow lane or left out. And we saw the National Insurance Contributions announcements as an example of that, in my view. How do we tackle that? Professor Ranger, you've made some comments about the new government really wanting to improve the NHS. How do we get over this problem of governments wanting to improve healthcare across the board, but continuing to return to acute hospitals because it's probably politically easier? How do we get over that?
You're absolutely right, and that's why I think there has got to be some shift to incentivise. You're absolutely right. I mean, why not for social care or for communities say, you become a nurse in those sectors, your university fees will get paid if you work for us for 3 years. There is something tangible around incentivise. You know, for the entire, you know, whatever sector you're in, as I talked earlier about being weighted to the bottom, why not do, you know, we want to have all nurses in every sector do what we do with paramedics and midwives. They're a band 5 for a year, 18 months, and they move to a band 6. All of this will incentivise all sorts of sectors and at least be able to get that stability, because the turnover and the retention is a huge part of the problem. So I would think about some really proper incentives, particularly in social care and community, particularly around 24-hour care. You know, because actually patients don't suddenly stop being, someone in a social care setting, things don't stop going wrong at 5 o'clock. So then you fall back in. What's the incentive to genuinely get 24-hour, 7-day-a-week care? I was recently in Belfast, an amazing district nursing service, 24 hours a day, 7 days a week. The difference that makes is huge. So wherever the need is, what's that little bit of incentive to do things differently?
It's also about leadership, isn't it? And it's got to come from the top. And permeate all the way down. We also need to be making sure that we're training our youngsters in leadership as well, so that needs to come through, because they're going to be the generation that will be looking after us sooner or later, and we want them to do it well. So I think it's also about the messages that come from the top, and also, you know, if the ICBs are told you've got to have a strong primary care voice at your top table, then they'll do it, otherwise they won't.
And also, particularly in social care, so many of the workforce are unregistered workforce. When you're competing with, you know, other sectors now that paying way above minimum wage, you know, all that stress, all that accountability, as well as the amazingness of working with people, which is always very fulfilling, people will actually say, do you know what, I just don't want the stress. When you're not paid your petrol or not paid your travel time, or I think people still love the job. It is, once I said earlier, it's the environment in which they're working. If we sort out some simple things, parking, travel time, petrol money, they may sound small things, but they're big things for the workforce.
Understood.
Thank you very much. Hopefully decision makers are listening. Thank you.
Very much. Danny Beals.
Thanks. I was going to ask actually about the investment standard, but it sounds overwhelmingly like you're in favour of an investment standard for either primary care or general practice or a combination. So I'll take a different track if that's okay. I was interested in really how we strike the right balance between moving away from prescription, from measuring, as you said, Beccy, the kind of frustration with QOF, and there seems an endless discussion about the adequacy or not of QOF, whilst continually adding new measures into QOF to try and deal with issues of variability, really, of care and patient expectation about consistency of what they're offered from practice to practice. I've worked for patient organisations previously, and it seems every patient organisation is desperate for a new QOF measure which addresses some of their concerns. So how can we strike that balance between moving away from prescription and those elements, but dealing with what we hear from patients and carers about the variability they experience from primary care across the country?
Yeah, I think variability is a really interesting one, because we need variability. It's really important that services in Fleetwood, up north of Blackpool, look really different to services in St Albans, where I live, because the communities are different and the needs are different.
Well, it's a challenge on that, but so if you're living with diabetes or a heart condition, would your local circumstance mean that you shouldn't have a care plan or you shouldn't have preventative education?
Absolutely not, but what that care plan looks like and how your care is managed might look different depending on what resources are available to you in your community. What I think is more interesting is thinking about what do local people think that they want, and how do they hold their local services to account. So if you ask local people what it is that they want their service to look like, and there's been plenty of places who've done that. Wigan is a great example where they've did some really interesting change, and again, Frimley, Fleetwood, lots of other places, they'll be very clear about what they want. And the danger with national prescription and national QOF is for the population. I use Fleetwood as an example a lot, I'm sorry. I think it's one I know well. up in Blackpool, they've got a population with huge mental health and drug and alcohol issues, and yet that is not prioritised through QoF. Yes, they've got diabetes, yes, they've got heart disease, but it's not where they want to put their prime focus. They need to put their prime focus onto drug and alcohol and substance misuse and child and adolescent mental health problems. That's where they want to put their energy. So there's something about setting basic standards, and that's where regulation comes in. Really important that we know what the basics are, but actually what the service looks like and how it delivers care for those populations needs to vary. The quality doesn't need to vary, and that's different. I would argue that QoF doesn't measure, it's supposed to be a quality and outcomes framework. It doesn't really measure quality, it measures process. And it doesn't measure outcomes either, despite being called that. It measures process. So yes, have some basic quality standards, and let's collect patient outcome data, because the outcomes need to be the same wherever you are, but the way you might achieve those outcomes can well be different, and that's a good thing. I think it's very hard to have a organisation which is not an organisation. The NHS cannot be run like an organisation. It's a very, very complex system, and in many parts of it, it's provided by independent practitioners, it's provided by voluntary services, it's provided by private sector companies, it's provided all over the place, and that's a great thing to have this real plethora of providers. You can't run it like a single organisation, and that's when I think things go wrong. We need to allow communities to determine and hold to account their local services.
And I think if we're really looking at patient outcomes, which I think everybody around this table is interested in, we've got national organisations that already produce standards in terms of NICE guidelines, which, you know, they need to be far more about the holistic patient. But also we've got CQC, we've got other bodies that can check that patient outcomes are being achieved, while allowing different regions to concentrate on what their locality really needs.
One of the challenges to that point is that NICE care guidelines are not implemented. You speak to any fundamentally basic care standards aren't implemented. Time and time again, there's huge variability in care. I'm sure there's good reasons for that.
It's very difficult in a 10-minute consultation. But having said that, certainly GPs are looking at NICE guidelines all the time, and all of our updating CPD is based around NICE guidelines. I think that really it depends on to what degree you're expecting guidelines to be implemented down to the last full stop. But, you know, again, a CQC type inspection, if it was properly organised and properly implemented, could check that patient outcomes were being, beneficially affected.
Is that only if the data is captured on whether those NICE processes are implemented, I suppose, and back to the point, if we're not measuring or collecting that data, you wouldn't know necessarily that one practice in an area isn't offering anyone, or isn't offering a very low level of their patients a foot check, which is a nice care standard.
Each practice gets its own individual CQC inspection, so you can inspect each practice. At the moment, CQC has been pronounced not fit for purpose, and it does need a huge reorganisation, which I'm hoping we'll get an opportunity to be involved with as well. But, you know, you could then be looking at patient outcomes within each individual practice.
Very helpful.
The other thing we've seen really effective as well is peer review. So the clinical effectiveness units in South London and in West London, for example, publish all that data between practices, and they hold each other to account. And actually that, I think, is a far more powerful way of looking at whether, so you can see that you're an outlier on flu vaccination or on diabetes care. Most clinicians, if I may say this, are very competitive, and they don't like to be the outlier. So by publishing that data, we've seen real success in that, and holding to each other to account locally rather than relying on punitive inspection seems to be very effective.
And that's when the CQC worked. Under Prof. Mike Richards' leadership, the CQC inspections were peer review. They were clinicians who did your day job, who then came and inspected your GP practice or your hospital or wherever. Now, that has stopped. It is not your peer reviewed. You are primarily reviewed by CQC employees, which always look through a slightly different lens. Peer review, that's how cancer standards got up when the Labour Party was last in power. That's how we, all their reforms in the beginning with CQC. That has gone down and down and down, and I think no longer fit for purpose, because that peer review element has disappeared.
And just briefly, if I may, Chair, I think that's really helpful. My final question was going to be about the role of patient and peer review, and in terms of accountability and dealing with variability at a primary care level. How do you think the role of patient voice and patient experience could be used, and patient participation groups seem some places to be a genuine engagement tool, but many not particularly effective from what I've seen. Again, would it be for peer review? Are there other thoughts you have about that?
So every GP, as part of their appraisal system, has to undergo a degree of patient review as well as peer review. But of course, I think we should be encouraging our PPGs to do more with practices. I think co-production with patients. And some of this is so that the public understand how to use the NHS, as well as that, you know, they're involved in developing and designing services that suit them, that work for them. And this is where that flexibility has to come in, the difference between Fleetwood and Farnham, for example. So I think it's a huge potential that we're not using well enough yet.
I think we did some work with the Grenfell Health System not long ago, where we talked to them about their experience of health and care after the terrible tragedy. And what we found is doing community engagement is not a token exercise, and I think too often across our health system we see community engagement as well. We've sent a leaflet out to our patients, so we've done it. Yeah. Actually, really listening to communities takes skill. It takes working with communities. It takes real investment. It takes headspace. All those things which are quite hard to find. But I think there are really amazing examples of how to do this well. But it's not easy, and it takes time and effort.
Thank you. In Craft for the final question.
I'm not super sure we've got lots of time. No. We're out of time entirely. I mean, the question was generally going to touch on the primary care estate, but I feel like we've opened the door to something massive. And that the government's ambition to have a neighbourhood health hub in every ICB area. What needs to happen to the primary care estate, basically, to deliver this?
I mean, I would say part of this will be, it is about investment. If you think about the cost of one new hospital is probably £1 billion. That would go a long way in primary and community services. I think there's more to do to think about how we make it easier for local authorities and other public settings to combine and use their estates together, because there's so many competing incentives that stops them working collaboratively around estate. The Institute for Government published a very helpful document on primary care estate, which I would commend, looking at some of these issues, but some of it's more technical than it is about finance.
Yes, we have calculated. Again, it's a back of an envelope calculation, but we think it would cost approximately £2 billion to bring primary care estate in England up to scratch from the surveys that we've done on our members. But I think it's going to be vitally important if we want to deliver the vision that the new government has got. I see a neighbourhood health service as having general practice as its core, with a primary healthcare team and multidisciplinary team around it, together then with the additional services that we're now getting from pharmacy, optometry, dentistry, and then around that, housing, social services, social care, citizens' advice, benefits, etc., helping people get back into work when they're ready to do so. But that could be done virtually. You don't need an actual hub. The hub bit I see as a diagnostic place, you know, where services can come out from hospital to do outpatient clinics. Hopefully there'll be plenty of free parking for patients, but also, you know, endoscopy, colposcopy, some women's health hubs, some community paediatrics, all of that, with the practices around that hub feeding in, and that would be my vision.
And mine, because you no longer want to diagnose in hospital. Diagnosis should happen outside. We shouldn't be admitting patients for a diagnosis. If they're well enough to go home, they should be absolutely confident that they can have a diagnosis via a community setting. And at the moment, we admit for diagnosis, which many other countries do not do.
Very helpful.
Thank you.
Right. Thank you so much all. As you hear from the bells, MPs are being called away. Thank you to all our panel members for contributing today. Much appreciated. Order, order.